Welcome to the deep dive. Today, we're really getting into something highly specialized, complex genital and urinary reconstructive surgery. We're working from this detailed case review of 37 patients, and there's also an AI analysis looking at, I think, 36 of those cases.
That's right. And our mission here really is to understand not just the technical side, the clinical landscape, but also the human element.
Right.
We're looking at how techniques have evolved, the microsurgery involved, and maybe most importantly, what really drives success for these patients functionally and psychologically too.
And the patient group itself is quite varied, isn't it? It's not just one thing.
Not at all. You've got penile cancer patients, people with severe trauma, congenital issues like hypospadias, micropenis, and also a significant number undergoing female-to-male gender transition.
That mix must give a pretty broad picture. What about age?
Well, the overall average was 38. But interestingly, the FTM group, the gender identity patients, they were quite a bit younger. Average age there was just 33.3.
Huh. So it suggests maybe the drive for transition leads to seeking the surgery earlier.
It could well be. Cancer or trauma might happen later in life, but the psychological need for affirmation seems to push things earlier for the GID group.
Okay, let's get into the reality of these surgeries. The complexity, the risks. It sounds like this isn't straightforward at all.
Oh, far from it. If you're learning about this, the first thing to grasp is it's rarely, almost never, a single operation.
Yeah, the data said only 3 patients managed it in one go.
Exactly. Just 3 out of the whole cohort. The average number of surgeries needed was 4.9, almost 5 operations per patient.
Wow, 5 times.
Yeah, and it comes with a standard deviation of 2.8, so there's quite a range. But still, on average, nearly 5 trips to the OR. It's a marathon.
And it sounds like these surgeons often deal with, well, problems from elsewhere.
That's a big factor. About 30% of these patients, nearly a third, were actually transfers. They came from other hospitals because their initial surgeries had failed.
Failed how? Like, what were the common issues?
Often severe complications. Necrosis, tissue death was a big one mentioned for the transfers.
So they're inheriting really difficult situations.
Absolutely. It forces a high degree of specialization in just fixing things. When you look at the overall complications in this study group, urethral problems were number 1.
Like leaks or blockages?
Yeah, fistulas, stenosis, strictures, that kind of thing, happened in about 25% of cases.
Okay.
And then necrosis, that tissue death we mentioned, was also significant, hitting 15% of patients, either partially or totally.
And it wasn't just about physical function failing, was it? Aesthetics mattered too.
Hugely. Poor aesthetic appearance was listed as a serious issue in another 15% of cases. The AI analysis tried to quantify success.
How did that look?
Well, it rated outcomes as excellent or good in about half the cases overall. That sounds okay, maybe?
But
poor results still happened in 6.7%. And when you consider what's at stake, your identity, basic bodily function, nearly 7% failure, represents a really significant challenge, both clinically and for the patient's life.
okay, so given these high stakes and complication rates, the techniques must have changed over time. What was the old way?
Back in the 80s and 90s, the go-to was often the radial forearm flap, the RF flap, sometimes with bone, sometimes just skin.
Right, the RF osteocutaneous flap.
Exactly. And the sources do point out, actually, that those early RF flaps could give very nice sensory recovery, nearly normal sensation, according to the tests they used.
That sounds like a big plus. Why move away from it then?
Well, sensation is great, but there were other long-term issues, especially with structural support. That forced the shift, really after 2000, towards a different flap.
Which was the SCIP flap, superficial circumflex iliac artery perforator.
That's the one, often used bilaterally, meaning from both sides, and frequently as an osteocutaneous flap, SCIPOC, incorporating bone.
And the AI analysis backed this up.
It did. The AI found the SCIP flaps tended towards more successful outcomes over the long run compared to the other options they looked at.
So what made SCIP better structurally? Was it the bone part?
Precisely. The SCIPOC technique involves taking the iliac crest that's part of your hip bone, along with its own blood supply. It's vascularized bone.
Living bone.
Living bone, exactly. It acts as a permanent internal stent. This was critical because earlier attempts using non-vascularized stuff like cartilage from a rib,
Yeah.
the sources say the body just absorbed it, gone within 6 months.
Sure.
So the structure would just collapse over time. You absolutely need that living, vascularized bone for lasting stability and length.
So the focus shifted from just sensation to ensuring long-term structural integrity. Makes sense.
Yeah.
Now let's talk about the urethra again. You said it was the biggest problem area. What was causing the failures there?
A lot of it came down to the materials used to create the tube itself. The sources are quite direct, using thin skin grafts, STSG, for the urethra lining. Just a complete mistake. Leads straight to blockage.
A complete mistake. Wow.
Yeah. And then there's the issue of hair.
Hair inside the urethra.
Sounds incredible, right? But if you use skin from an area that normally grows hair, like the thigh or sometimes the forearm, that hair keeps growing inside the new urethra.
Oh, no.
Yeah. The source says it causes stenosis, strictures. The hair traps debris, gets calcified, and eventually you get stone formation. Total obstruction. A real nightmare scenario.
So you need something reliably hairless and tough. What was the solution?
The breakthrough described here is using the appendix.
The appendix, like your actual appendix.
Yes, transferred with its own blood supply. Sometimes they even need to extend it with a bit of the cecum, part of the large intestine, to get enough length. But it's naturally hairless. It's a tube, and it's vascularized.
That sounds technically unbelievable. The blood vessels must be minuscule.
They are. The surgeon calls it nanomicro technique. We're talking vessels around 0.2 millimeters. It's pushing the absolute limits of microsurgery.
0.2 millimeters. Wow. And why is the appendix tissue better than, say, a skin tube, even if you could guarantee no hair?
It's resilience. The appendix wall doesn't erode or tear easily, especially when you need to dilate the urethra post-operatively to keep it open. This is super important for patients who've had radiation, like for cancer.
Ah, because radiation damages tissue fragility.
Exactly. Irradiated tissue is notoriously prone to scarring down, causing stenosis. But the appendix conduit holds up much better, even in those really difficult high-risk cases.
So the material is crucial. What about the shape, the size?
Also critical. The surgeons emphasize making a larger urethra is very, very important, just to build in a safety margin against stenosis.
Makes sense.
And for the opening, the meatus, they use a special technique called a hinge flap. The goal there is to create a really good linear stream for urination.
Which is important for?
For standing to urinate. Functionally and psychologically, being able to stand and urinate confidently in a public restroom, for example, is a huge deal for many patients, especially the FTM individuals.
Okay, that brings us to the psychological side, which seems just as important as the plumbing here.
It really is, particularly for the gender identity patients. The sources show they often define the reconstructed phallus primarily as a symbol of male. It's about pride, identity affirmation.
More than just sexual function initially.
Often, yes. Standing urination is repeatedly mentioned as a key part of feeling and being recognized as male.
That story about the 80-year-old cancer patient was striking. He wasn't concerned about function at all, was he?
No, it was entirely symbolic for him. He wanted the reconstruction because he feared the big shame, as he put it, of his body being seen without a penis after he died. It shows how deep that need for bodily integrity, for identity, can run right to the very end.
That kind of motivation really underscores the importance of this work. And speaking of innovation driven by need, let's talk about this dancing penis. What's that about?
Right. So the modern technique using the bilateral SEI-POC flap often gets combined with wrapping a gracilis muscle, a muscle from the inner thigh around the base.
Okay. And this causes movement.
Apparently so. It results in what the surgeon calls a dynamic penis. It can actually move or dance.
And patients react well to this?
Extremely well, especially the GID patients. They reported big pride in this movement, showing it off in public baths, even on buses, apparently. It's seen as another sign of successful transition, of vitality.
Wow. Is there any functional benefit beyond the psychological boost?
Actually, yes. The source mentions another prominent female microsurgeon who presented findings that this dynamic movement is considered very important for the sexual satisfaction of the female partner during intercourse.
Interesting. So it enhances sensation or interaction for the partner.
It seems so. What started perhaps as an unexpected outcome of the muscle wrap turned out to have real benefits for intimacy. So if we boil down the key clinical lessons from this deep dive, what are they?
Well, first, you absolutely need that vascularized bone, like the iliac crest for long-term structure. Non-vascularized stuff just disappears.
Right. Crucial point. What else?
Second, cracking the urethra problem. That meant ditching hairy skin and STSG and embracing something non-hairy, vascularized, and robust, like the appendix transfer, especially for irradiated cases.
The appendix was a game changer there.
And third, just accepting the complexity, recognizing that this usually takes multiple stages. Patience and meticulous correction are key. not a quick fix.
Absolutely. Surgical skill has to be matched with persistence.
It's really incredible how this kind of super specialized surgery drives innovation in materials technique. But you mentioned something earlier that suggests these insights might connect to completely different health problems.
Yeah, it's fascinating how focusing intensely on one area can spark ideas elsewhere. We're currently looking into severe senile lymphedema chronic swelling, usually on the legs of older people.
Okay.
And the kind of microvascular analysis we do in reconstruction is making us wonder if there's a link between the mechanisms causing that swelling and amyloidosis.
Amyloidosis, that's linked to Alzheimer's disease, isn't it?
It is. It involves protein misfolding and deposition. So the thinking is, could the micropathology we see in lymphedema, which we dissect with these advanced techniques, actually share molecular pathways with major systemic diseases like Alzheimer's? It's early days, but it's a potential connection born from this kind of niche surgical focus.
That's quite a leap from reconstructive surgery to potential links with neurodegenerative disease.
It shows how interconnected things might be at a microscopic level.
So we'll leave you, the listener, with this thought to consider. If these highly specialized surgical techniques developed for extreme reconstruction can potentially shed light on molecular pathways and seemingly unrelated conditions like lymphedema and maybe even amyloidosis, where else might deep, niche expertise unlock hidden biological connections across the whole landscape of human health? Something to think about. Thank you for diving deep with us.